Thank you. Now, you have to excuse me, I'm mildly technologically challenged. What to expect when you're not expecting the menopause? First up, we start with the perimenopause, which is the several years leading up to the time of menopause, where cycles may shorten or lengthen. Shorten if you're unlucky, lengthen if you're lucky. Levels of estrogen are variable and some cycles may be anovulatory. That is, you don't ovulate in them and don't make the same levels of estrogen in the same number of eggs. Menopause is simply the date of the last menstrual period. This is defined retrospectively, so when you've not had a period for a year, that's menopause. If you have a period during that year, you start again at square one. It's generally between the ages of 45 and 55, with the average being 50 or 51. Early menopause is defined as before 45, and premature menopause or premature ovarian failure is before 40. Now, I've had some women as young as 20, 21 who are menopausal, so anybody in the audience could be suffering from the effects of menopause. It happens because our eggs are running out. We start off with 6 million eggs as a fetus. By the time we're born, we've lost some. By the time we reach menopause, we've lost them all. Eggs are what produces estrogen, and as you go through the time of menopause, you may not cycle so regularly and may not produce so much estrogen. So your periods begin to change. Cycles may be shorter or longer. Periods may get lighter or worse, heavier. Periods may be missed, yay. If there's more than a 7-day change in your menstrual cycle, this may be perimenopause. Hot flushes may occur. The intensity and frequency of these vary. They can happen any time of the day or night. And sleep is disrupted, sometimes from hot flushes, sometimes just because. And your fertility reduces. Now, it doesn't become suddenly infertile. We recommend that you use birth control for the 12 months after your last menstrual period if you're over 50, and for 24 months if you're under 50. Suitable contraceptive methods include the IUD, the Mirena, the progestogen-only pill, and in some cases the combined oral contraceptive pill, which acts as a form of hormone replacement therapy. There are changes in sexual function, but the good news is, if sex is good, it should continue to be so. Bones start to thin. And there'll be changes in your cholesterol. So the good cholesterol goes down and the bad cholesterol goes up. Just what you need. And the very best part of it, the mood changes. Worsening PMS symptoms, including breast tenderness, forgetfulness, problems with thinking, memory and concentration, mood swings, irritability and increased risk of depression. Some of this is due to night sleep disruption because of hot flushes, but some of it is just because. And there are changes in the vagina and bladder. Loss of lubrication and elasticity of the vaginal tissues, making intercourse painful. Low estrogen increasing the vulnerability to urinary tract infection and vaginal infections. Loss of muscle tone leading to urinary incontinence. Sounds great, doesn't it? Now, the good news is not everybody will have all of those symptoms, but those are the symptoms of menopause. And if you've got a number of them, then you may be menopausal or perimenopausal and may benefit from some treatment if that's appropriate for you. These are some of the risk factors for earlier menopause. So it's always worth talking to mum, finding out when she went through menopause and how she experienced it. If you've had surgery on your ovaries, such as an oophorectomy, that's removal of an ovary, or had a cyst removed from the ovary, then you're at risk of earlier menopause. Also, if you've had a hysterectomy, menopause occurs on average 2 or 3 years earlier. Diagnosis is by history. Blood tests are not helpful. The only situation where we really use them is the women under 40, where we're trying to work out if they're premature menopause or not. Now, most of this will be covered by other speakers, but eat healthily, avoid caffeine and alcohol, use vaginal moisturisers and lubricants, stay sexually active, be physically active, get enough sleep. Mindfulness-based therapies help, as does acupuncture. There are a number of treatments for menopause that are non-hormonal for the women who can't take hormones, and that includes breast cancer survivors. The SSRIs are an antidepressant, and the one that's used particularly is paroxetine. Gabapentin is an anti-epileptic agent, but will also help with hot flushes, as does venlafaxine, which is another antidepressant. Clonidine is an antihypertensive, and given in small doses may help with hot flushes. Unfortunately, the non-hormonal treatments really only treat hot flushes, and many women are inconvenienced by other symptoms. So when do you seek help when your periods go awry? If they're excessively heavy, so if you're bleeding changing more than 2 to 3 hourly, or bleeding through your protection, or having to get up at night. If there's bleeding between the periods or after intercourse, that's a real red flag and you should see your doctor. When cycles are regularly less than 3 weeks, or when bleeding lasts for more than 7 days. We have a number of treatments available for this, including tranexamic acid, which is an agent that stabilises the blood clot and bleeding blood vessels in the uterus. It works very effectively and is the only non-hormonal option for managing heavy periods. This is a Mirena intrauterine system. It makes the lining of the uterus thinner and reduces the heaviness of bleeding very effectively. In fact, it's the best option for treating heavy periods. Doesn't work for everybody, but if it works, it's fantastic. It's also highly contraceptive, so if you're in that perimenopause phase and needing birth control as well, a Mirena is often a really good option. This is a NovaSure endometrial ablation device, which is a device that sits inside the uterus, put in under an anaesthetic, and the aim is to destroy the lining of the uterus and control heavy bleeding. Pregnancy isn't recommended after this, so it's only suitable for women who've completed their family. You may also be offered sterilisation at the same time. And then we come finally to hysterectomy, and it is the last option. Usually we do a total hysterectomy, that's removal of the uterus and the cervix, with both tubes being taken at the same time, and that's to reduce the risk of ovarian cancer. Sometimes we'll do a subtotal hysterectomy. There is some evidence that this may improve sexual function post-hysterectomy. MHT or HRT is a combination of estrogen and progestogen, given either orally or transdermally. and the progesterone has to be given orally. Sequential therapy is given to women who are still having menstrual cycles or within 12 months of their period stopping, and it's a combination of estrogen on its own for 2 weeks and estrogen and progesterone together for 2 weeks. Sequential therapy is for those who are a little bit further along the line, who have finished their periods more than a year earlier. And that just means you take estrogen and progesterone in a smaller dose continuously. The aim of the exercise is to treat with the lowest possible dose for the shortest possible time, but remember that for many women, menopause lasts for many years. There are some risks with taking HRT, and these include venous thromboembolus or blood clots. The blood clot risk is increased with oral HRT, but not with transdermal preparations. Cardiovascular risk. There is no evidence that MHT increases the risk of cardiovascular disease or dying from a cardiovascular disease. Risk depends on personal risk factors, and that's a conversation that all of you should be having with your GPs around the time of menopause. Estrogen alone HRT reduces the risk of cardiovascular disease by a small amount, but combination HRT is associated with little or no risk, increase in the risk of cardiovascular disease. Stroke risk. There is a slight increase in stroke risk with combination HRT. So, sorry, I should explain. Combination HRT is estrogen and progestin HRT. Estrogen alone is given to women who've had a hysterectomy. There is no evidence of an increase in risk of diabetes. HRT doesn't affect your sugar control, so if you're diabetic, you can still take it. Breast cancer is the biggie. Estrogen alone, MHT, is associated with no increase and possibly a decrease in the risk of breast cancer. Combination MHT is associated with a small increase in the risk, with the background risk being 63 per 1,000 women, and combination MHT increasing that risk by 17 cases over 5 years. Risk reduces with times after stopping MHT, and there is no evidence of an increased rate of death from breast cancer in women who are taking MHT. It does reduce the risk of fragility fracture. The longer you take it, the better. Dementia risk with MHT is unknown. That's currently being researched. And lack of muscle strength and mass may be reduced by MHT, but this relates largely to activity, and we'll cover that later. Testosterone is something that people often ask about. It's sometimes added to MHT, but only when you're on estrogen and progesterone together, and the only indication is for hypoactive sexual desire disorder, a mouthful. What that means is that you've lost your libido and it's distressing. That's the only indication in New Zealand for use of testosterone, but some people will report increased energy after using testosterone. There are a couple of preparations available. Androfem, which is a cream, it's not funded and costs about $150 for 3 months supply. And Testogel, which is the male version, which of course is fully funded. That's given in smaller doses to women. Vaginal estrogen is used for genitourinary syndrome of menopause, previously known as atrophic vaginitis, or the problems with vaginal dryness, irritation, recurrent urinary tract infection and vaginal infections, and urinary incontinence. It's very helpful in all of those areas and is given either as a pessary or a cream applied to the vagina. Thank you.